they have to sit. Good afternoon and welcome you all to this teleconferencing session. This teleconferencing session is devoted to Course 2, that is Reproductive and Child Health of Certificate in Competency Enhancement Program for A&M and Health Workers. For Block 2, that is Essential Newborn Care. In this teleconferencing session, we shall be talking about neonatal resuscitation. To discuss this topic on neonatal resuscitation, we have two experts. We have Professor Anm Fhw-1, who is Professor of Pediatrics at Maulana Azad Medical College. He is also at present the President National Neonatology Forum. We have Dr. S. Saluja, who is Senior Consultant in Gangaram Hospital in Department of Child Health, and he is also at present the Secretary National Neonatology Forum. This neonatal resuscitation, as you all know, is when the baby is not able to breathe properly, he may need the resuscitation. Normally, the newborn baby does not need any neonatal resuscitation, and the baby cries and breathes spontaneously at birth. But what all care he needs at birth is just cleaning, wiping, drying, covering and feeding, and then putting the baby to the mother's breast. But if due to certain problems, if the baby is not able to breathe spontaneously, and these problems could be either maternal, fetal or placental, then you have to initiate neonatal resuscitation. And for this purpose, you need to develop the skill of neonatal resuscitation and also recognize the problems that the babies have at the time of the birth so that you can initiate the appropriate steps. So I would request Professor Anm Fhw-1 to start the session.
20% of newborns require some help at the time of birth. So the transition at the time of birth from intrauterine life to extrauterine life is very crucial, because asphyxia can have its origin even before the baby is born. That's why it is called a perinatal asphyxia. It will begin before the birth of the baby. It can be there during labor, and it can be there after the delivery. 20% of the babies would require some assistance at the time of birth. So at the time of birth, it is very important to be well prepared for the birth, to have adequate number of personnel available to help in resuscitation of the newborn. The person who is there to resuscitate the newborn must be well skilled, and he should have practiced well before he is actually providing care on the patient. So now let us see the important aspects of resuscitation.
Just click the mouse. The arrow wala niche kar do. Yeah, just keep pressing.
Right at the time of birth, the first and foremost thing is to assess the baby at birth.
We don't have it on the slide.
Keep the baby warm, put him in proper position, clear airway, stimulate to breathe by drying, and give oxygen. Then the next step is establish effective ventilation through bag and mask ventilation and through endotracheal intubation. Next step is provide chest compression, and then the next step is administer medication. So this neonatal resuscitation is a stepwise approach in which you administer these steps in a sequential manner, and the steps which are at the top are the ones which are required most frequently in a large number of babies, whereas the steps which are at the bottom of this inverted pyramid are required in the smallest number of babies, because these are less frequently required. When you are doing resuscitation of the newborn, to prioritize your action, you first need to evaluate the baby. Based on your evaluation, you have to take a decision, and based on that decision, you have to act. After taking action, you have to again evaluate the baby, and then again follow this cycle of making a decision, and again taking an action, and then again evaluating. Now, as I said, it's very important to be prepared for resuscitation. So preparation for resuscitation includes, number one, anticipation for the need of resuscitation. For example, there are certain conditions in which resuscitation would be required, particularly if the baby is preterm, if there has been meconium stained liquor, if there has been maternal hypertension, maternal diabetes. Those would be the condition in which you would be anticipating a need for more steps in resuscitation. Then the second point is adequate preparation of equipment as well as personnel. For the delivery, we have to check that the equipment is there and it is functioning or not, and adequate number of personnel have to be deployed to provide resuscitation at birth. Now, although we plan to anticipate our actions, however, the need for resuscitation may also come as a surprise. So there may be no risk factors requiring resuscitation, but still the baby may require resuscitation. So far as the personnel are concerned, at least 2 people are required to resuscitate the baby. And the equipment which is required, the most important is a radiant warmer or a heat source. This should be heated and ready to use. The radiant warmer should be switched on even before the delivery. All resuscitation equipment should be immediately available at the resuscitation corner, and it should be in working order. For high risk cases, there would be 2 or more persons required for resuscitation, and if there are multiple births, for example, if twins are delivered, then there would be 1 team required for 1 baby. So you would require double the number of people. Now this is a list of the equipment and supplies which would be required for resuscitation. So you require a radiant warmer, you require gloves, then some suction catheter or suction device is required, a stethoscope is required, a shoulder roll is required, blankets or towels or linen would be required to wrap the baby and dry the baby, and a self-inflating bag would also be required. Then we require flow meter, masks, method to administer oxygen, laryngoscope and blade, suction catheter, endotracheal tube, meconium aspirator, a clock with second hand, and a mechanical suction device and tubings. So these would be the equipments and supplies which would be required to provide resuscitation at birth. Now this is the stepwise approach that we follow after the birth. So at the time of birth, the most important thing is to check 4 points. The first point is the liquor clear of meconium or infection? Then the second point is the baby breathing or crying? The third point is the muscle tone of the baby good? And the fourth point is the gestational age of the baby full term or not? So these are the first set of 4 points that you need to evaluate right at the time of birth. If the answer to these 4 points is yes, that means all these conditions are favorable, that is the liquor is clear of meconium, the baby is either breathing or he is actively crying, his muscle tone is good, and he is of full-term gestation, then this baby requires only routine care. In routine care, the care is provided on the trunk of the baby, of the mother. So the baby is placed on the trunk of the mother, on the chest of the mother, where he receives the warmth of the mother, that is the body warmth of the mother. He is dried there, and his airway is cleared, his mouth is suctioned and his nose is suctioned. He is dried, and then he is assessed and observed. However, if the answer to these 4 points is not favorable, that is, there is meconium stained liquor, or the baby is not breathing, he is not crying, or the muscle tone is not good, or the gestation is not term, then in that case the baby would be requiring what is called initial steps of resuscitation. So in these initial steps of resuscitation, this care is provided under a radiant warmer in a resuscitation corner. So the first step is that you provide warmth. Then the second step is that you position the airway. So for positioning, you have to position the neck in a sniffing position. Sniffing position is a position of the neck in which the neck is in slight extension. As you sniff a flower, you slightly extend your neck. So that is the position which is appropriate for resuscitation. So you provide position of the neck. The baby is laid flat on a firm surface. Then we clear the airway. In clearing the airway, we first suction the mouth, and then we suction both the nostrils. Then after that, the baby is dried. In drying, we use a sheet or a towel by which the baby's parts are dried, and then he is repositioned, and then he is given a physical stimulation. So these would be the initial steps of resuscitation. Now, right from the assessment of the 4 points and the provision of initial steps, the total time required to provide this care is 30 seconds. So this much care should be provided within 30 seconds of birth. After this, the baby is evaluated for respiration, that is, whether spontaneous respiration is present or not. The second point for evaluation is you evaluate the heart rate. So you auscultate the heart for 6 seconds, calculate the heart rate, and multiply by 10 to get the heart rate per minute. And then you assess the color of the baby, in which you see the color of the lips. If the lips are blue, it is supposed to be central cyanosis. If the extremities, that is the palms and soles, are blue, then it is peripheral cyanosis. So it's more important to observe for presence of central cyanosis, which is more severe. Now if the baby is breathing and his heart rate is more than 100 and his color is pink, then what he requires is only observational care. If the baby is breathing, his heart rate is more than 100, but he has got central cyanosis, then he will require supplementary oxygen. This supplementary oxygen is given for a period of 30 seconds or as long as it is required, till the baby is pink so far as his lips are concerned. And once he becomes his lips become pink, then he qualifies for observational care. However, if on evaluation of respiration we find that the baby does not have spontaneous respiration, which means he is apneic or he is having gasping breathing, or if his heart rate is less than 100 per minute, in that case there is an indication to provide positive pressure ventilation. So the two indications for positive pressure ventilation would be if the baby is apneic or if his heart rate is less than 100 per minute, or if after administering 100% oxygen for 30 seconds there is persistence of central cyanosis, then also there is an indication to provide positive pressure ventilation. Now this evaluation and provision of positive pressure ventilation should continue for 30 seconds. The ventilation has to continue till the heart rates are more than 100 and the color of the baby's lips is pink. Once that is achieved, then the bag and mask ventilation can be discontinued. However, such babies would require post-resuscitation care in a nursery. If on providing positive pressure ventilation the heart rate continues to be less than 60 per minute, then along with positive pressure ventilation there would be a need to administer chest compression. On administering chest compression for 30 seconds, if the heart rate improves, it becomes more than 60, then only bag and mask ventilation has to continue and chest compression can be discontinued. However, if after 30 seconds of effective bag and mask ventilation and chest compression, if the heart rate is less than 60, then this baby would require medication and the positive pressure ventilation and chest compression would continue. So this is an overview of neonatal resuscitation.
Dr. Mathur, you have just said about initial steps of resuscitation, and you have mentioned that the provision of warmth, the positioning, the evaluation, the stimulation are very important. As we know that the suctioning is also one of the important part of the stimulation of the newborn baby. What points that health workers should keep in mind while resuscitation? That is number one, while suctioning. And the number two is that when the baby is being given tactile stimulation, what points a health worker should remember while he or she is giving tactile stimulation during the initial steps of resuscitation?
Well, it is very important that while the suctioning is being done, either a delete trap or a bulb syringe should be used so that the pressures are not very high. The oral cavity must be suctioned first to clear the secretions, because if we apply suction to the nose first, then that is going to stimulate a breath, and whatever secretions are there in the mouth, in the oral cavity, those would be aspirated. So it's important to remember that suction of the mouth should precede suctioning of the nose. So to sum up, in the initial steps, it's very important to ask about these 4 points right at the time of birth. That is the amniotic fluid clear of meconium? Number 2, is the baby breathing or crying? Number 3, is there good muscle tone? And number 4, is this baby born at term?
Yes, we also talked about giving the tactile stimulation, and because there has been practice earlier that the baby used to be slapped on the back and at the put upside down, and these practices should not be followed now. So what are the exact practices which should be followed during tactile stimulation?
It's very important to be gentle while providing the tactile stimulation. So tactile stimulation would consist of gently slapping the baby on the sole or flicking the baby with the finger over the sole, or rubbing the baby at the back. Now this is what is tactile stimulation. It can be provided over the soles or at the back, and it should be given only twice. That is, you give 2 flicks over the sole or you rub the back twice firmly.
Okay.
So this is what is advocated for tactile stimulation. Certain harmful practices which must be avoided at the time of providing tactile stimulation and which used to be followed in the past used to be putting the baby in hot and cold water bath alternately, or very harshly slapping the baby. This can cause injury, it can even cause hematomas to the baby. And then there used to be a practice of dilating the anal sphincter to make the baby breathe. All these are not acceptable. So what is required is just gentle stimulation of the baby, and that is what is recommended.
So you have said that once after initial steps and suctioning and tactile stimulation, and after evaluation, if you find that the heart rate has not improved and the respiration also has not improved, then bag and mask is indicated. So I would request Dr. Saluja to start with the bag and mask respiration and discuss about what points should be taken into account while giving the bag and mask respiration.
Good afternoon. Now what we have learned today is that 90% of the babies who are born, they don't require much assistance at the time of birth. They either require some bit of assessment and then they are taken care of with the mother, or they would require some bit of stimulation, tactile stimulation, to make them breathe. So the key is that all those babies who are not able to initiate breathing at the time of birth, and if after performing initial steps for 30 seconds they are still not breathing, then these babies need help. That means we need to help them to breathe. What we have learnt is that we have to assess them in a particular sequence. We have to assess their breathing, which means whether they are breathing or not, which in scientific terms means whether they are apneic, or if they have gasping respiration, they have jerky respiration, so that is also an abnormal breathing. The second assessment is checking up for their heart rate. Normally the heart rate is more than 100, but if it is less than 100, that is an abnormal heart rate. Those babies who are breathing well, who have a good heart rate that is more than 100, but still have central cyanosis, that is on the lips and the central part of the body, will also require assistance. So all those babies who have got initial steps of resuscitation, if they are not breathing or have a gasping respiration, or even if they are breathing, their heart rate is less than 100, or if they are breathing well, their heart rate is more than 100, but in spite of giving free flow oxygen to the baby on the mouth and the nose, baby still has central cyanosis, then comes the role of assisting or helping their breathing with the help of what is called bag and mask ventilation. I am sure some of you would have seen this equipment, which is the resuscitation bag. This is the commonly used resuscitation bag, which is called self-inflating bag. which means this bag inflates on its own. If you looked at this clearly, when you press and release, it inflates on its own. That is why it is called a self-inflating bag, which is commonly used to assist the breathing of newborn babies who are not able to breathe. So what have we learned? We have learned that those babies who after 30 seconds of initial steps, as has been told by Dr. Mathur, are either not breathing, or if they have gasping respiration, or if their heart rate is less than 100, or if they still have central cyanosis after giving them free flow oxygen, then we need to use this equipment to assist their breathing. Now let's look at what are the parts of this bag. Just leave this. This central part of the bag is the body of the bag, from where we deliver a positive breath to the baby. When we press this, a breath from this side goes into the baby, and when we release this, it fills up again. At the back of this bag, there are two ports. Can you see this small port and the bigger port? This small port is the oxygen inlet, and this is connected to a tubing which is connected to the oxygen cylinder. This tubing, the other end of this tube goes into the oxygen cylinder, and this end is attached at the back of the bag, which is the oxygen inlet. There is another inlet at the back which is called the air inlet, which allows this bag to refill on its own when we relax this. Now when we don't attach this oxygen and we give a positive pressure breath to the baby, we give breath with the room air, and we know that the room air has 21% oxygen. When we connect this oxygen source to the bag and then give a positive pressure breath, we give something like 40% oxygen. But if at the air inlet, the bigger inlet at the back of the Anm bag, if we were to connect a device which is called reservoir, when we connect this reservoir, this gets filled up with the oxygen which is coming from this tube, and then we are able to deliver almost 90 to 100% oxygen. So a baby who is not improving with lower concentration of oxygen, we should use this reservoir so as to give higher concentration of oxygen so as to improve the baby's oxygenation. The reservoirs are of two types. You can see this is a closed-ended reservoir, or you could have an open-ended reservoir, some tube like this which gets attached here. Then there are certain valves in the bags which help functioning of the bag. Now I don't know whether you can see it here or not. When I press this, there is a yellow color valve here which opens up only when I press this. Can you focus it here? No, we can't focus more than this. Can we have a closer? Okay, that doesn't matter. Now when I press this, there is a valve which opens up during inspiration, and this is called inspiratory valve. And there is another valve here. If I was to open this, now this is the inspiratory valve which allows the breath to go only into the baby. You can see this opening up now. Yes, it allows the breath to go only into the baby, but it doesn't allow the gas to come back from the baby into the bag. If this is not functioning well, your bag will not function very well. Then there is an expiratory valve here which is supposed to be a yellow colored valve here, which is called the expiratory valve, which allows the babies to breathe into this port and the gas comes out from this port. So the exhaled gas from the baby doesn't go back into the bag. Then there is a safety mechanism. The safety mechanism is this pop-off valve. If we were to use very high pressures, then excessive pressures are leaked from this valve, which is a pop-off valve. When I attach it to the baby and press it very hard, this pop-off valve, which is a safety, something like a pressure cooker valve, if by mistake you were to generate a very high pressure, so that the high pressure is not delivered to the baby and it is leaked from this safety valve or the pop-off valve. Now how do we use this? With this device, we have to connect a mask. This is the mask which is connected to the AMBU bag or the resuscitation bag, and with the help of this we give breast to the baby. If you were to look at this, can you focus here? Yeah, this is the baby, and if you were to put this mask over the baby's mouth and nose and make a tight seal between the face and the mask, and when I press the bag, it gives a positive pressure breath to the baby. Now let's talk about the mask. Now the masks come in various sizes. This is a small mask which is for the premature baby. This is a bigger mask which is for a term baby. If you look at the margins of this bag, these are cushioned. There are also certain masks which are non-cushioned. The advantage of having a cushioned mask is that when you place it over the baby's face, it doesn't damage the skin of the baby. And if this cushion was not there, it doesn't make a very good seal, and to make a good seal you have to press very hard on the baby's face, and that can cause trauma over the baby. These are circular masks. There are also certain masks which come as anatomical shaped, which are sort of triangular shaped, which fits over the baby's nose and the mouth like this, but these are circular masks. Now what we have to do is, we have to attach this mask to the AMBU bag, and to check if this is working appropriately, we place it against the palm and then give a positive breath. If there is a tight seal, we should be able to feel pressure on our palm. If we are able to feel a pressure on the palm, that means this equipment is working well and we can use this for giving a positive pressure breath. Now how much this mask should cover the baby? If you look at the baby's face anatomy, then it should cover the chin. It should cover the chin, the mouth and the nose. Similarly, when we look at the baby's face, this mask should cover the chin, the mouth and the nose. So we enclose the nose, tip of the chin, the mouth and the nose, but it should not cover the eyes of the baby, otherwise will cause more damage to the baby's facial structures. And once we make a good seal here and give a positive breath, then you should be able to see the chest of the baby rising. Can you see here? Just focus here. We'll demonstrate this more when we give the practical sessions. So when we give a positive breath, the chest rises up and goes down. One thing which we have to emphasize is that the baby's position should be flat on the back and the neck should be slightly extended like this. And this is the best position for performing initial steps, for giving bag and mask ventilation and other steps of resuscitation, which we'll talk about in subsequent sessions. Now, what should be the rate of giving positive pressure breaths? We know all babies breathe at a rate of 40 to 60 breaths per minute, and if we were to practice squeeze and 2 and 3, squeeze and 2 and 3. When I say squeeze, then you should press the bag like this. So squeeze, 2 and 3, squeeze and 2 and 3. If you were to practice in this rhythm, you will be able to give something like 40 to 60 breaths to the baby. So you place it well and say squeeze and 2 and 3, squeeze and 2 and 3, squeeze and 2 and 3. So by giving this rhythmic contractions to the bag, you are able to deliver 40 to 60 breaths to the baby. Now what do you do when you are giving positive pressure to the baby? If you are able to see the chest rising, if you count the heart rate and the heart rate is rising, the baby's color is improving, baby's tone is improving, it means that the bag and mask ventilation has been effective. But what do you do if you feel the baby is not improving? Now the reasons could be either your seal is not good, that means this mask is not fitting well onto the baby's face, you are not applying enough pressure, or there are some secretions in the baby's oral airway. So you should clear the airway. If there are any secretions, clear the airway of those secretions. Make sure your equipment is fine. Make sure you are having a proper seal, and make sure you are applying appropriate amount of pressures to deliver positive pressure breaths. Yes, Dr. Kitika.
Suppose, how does the health worker identify that the mask is not, the seal has not been properly made and the child is not improving? What actions she should take at that time?
If the baby, as I said, baby is not improving, you take away the mask from the baby's face, reapply covering the tip of the chin, mouth and the nose. Make sure that the baby's position is in slight neck extension. If there have been some secretions, you can clear the mouth and the nose. If there was meconium and the baby is not breathing, you have to perform endotracheal suctioning first. Then after you have cleared the airway, after positioning the baby properly, reapply the seal and make sure you are delivering enough pressures so as to expand the chest and result in improvement. If still it doesn't happen, that means after you have taken care of all these steps and in spite of giving bag and mask positive pressure breaths, the baby is not improving, then you should consider doing an endotracheal intubation and give positive breaths through the endotracheal tube.
Suppose after bag and mask respiration to the baby does not improve. What is the next step which is?
You see, we have said that all steps of resuscitations are performed for 30 seconds. If after 30 seconds of initial steps the baby's breathing is not improving, we give bag and mask ventilation. And if after giving 30 seconds of effective positive pressure ventilation the baby's heart rate is not improving, then we should go to the next step. When I say heart rate not improving, which means if the heart rate is less than 60, and how do we know 60? That means we counted 6 beats in 6 seconds and it is 60. So if you have counted 5 or less in 6 seconds, that means heart rate is below 60. Then we go to the next step, which is along with the positive pressure ventilation with the bag and mask, we start chest compressions, and chest compressions will be taken by Dr. Mathur.
How, suppose the health worker has to check the heart rate. How does she check the heart rate?
There are 2 ways of checking the heart rate. You see, when a newborn baby is born, we have the umbilical cord, and very often during initial resuscitation you can feel the pulsations in the umbilical cord. So you place your index finger and the thumb around the umbilical cord and you count the heart rate, looking either at the seconds, or you can keep tapping on the table the number of times you count the heartbeat or the pulse over the umbilical vessel. Now then you count these beats in 6 seconds. For example, we count 3 in 6 seconds. Multiply this by 10. 3 means the heart rate is 30 beats per minute. If you count 6, that means the heartbeat is 60 beats per minute. If you count 9, that means the heartbeat is 90 beats per minute. And if you count 14, the heart rate is 140 beats per minute. And other way of counting heart rate is that you could use a stethoscope. Take a stethoscope and put it over the baby's chest, and then you can count the heart rate in a similar fashion over a period of 6 seconds and multiply that count by 10 and you get the actual heart rate.
Okay. Dr. Mathur, will you start now chest compression for if the baby does not improve from bag and mask respiration and we need to give chest compression. So what are the indications of the chest compression of the baby?
When a baby is requiring chest compression, number 1 is he has undergone the initial steps of resuscitation, which have been performed over a period of 30 seconds. Subsequent to that, he has been evaluated and he has received bag and mask ventilation for 30 seconds. After giving bag and mask ventilation for 30 seconds, if the baby's heart rate is less than 60 per minute, then there is an indication to provide chest compression.
Dr. Mathur, I would just interrupt in between. You have said that if this bag and mask compression with the bag and mask are given for 30 seconds. So how can she identify how many compressions she should give at a time? Not the chest compressions, the inflations, the bag and mask.
The bag and mask ventilation has to be given at the rate of 40 to 60 per minute. And as has been told to you by Dr. Saluja, if you keep saying breathe 2, 3, breathe 2, 3, and when you say breathe, you give a breath. So breathe 2, 3, breathe 2, 3. That way, when you give breath to the baby through a bag and mask, then you would be giving breath to the baby at a rate of between 40 and 60 per minute. This has to be done over a period of 30 seconds, which means over 30 seconds you have given something like 20 to 30 breaths to the baby through the bag. At the end of that, you evaluate the baby for a period of 6 seconds. And if the heart rate is less than 60 per minute, then there is an indication to give chest compression.
Dr. Saluja has just mentioned that they have to say squeeze and 2 and 3. Is there any difference between, as you said, breathe 2 and 3 and squeeze and 2 and 3? Does it have some time interval gap, or they can, either of the two can be used while they are giving bag and mask ventilation?
While you are giving bag and mask ventilation, when you say breathe, you are giving the breath through squeezing the bag and mask. So, which means that you squeeze the bag when you say breathe, and 2 and 3 is the time when the bag relaxes. So when you say breathe, you are squeezing the bag, and at that time a breath is delivered, and when you say 2, 3, that time the bag is inflating. So that is the way to give breathing to the baby through bag and mask at a rate of 40 to 60 per minute. Now, having done that for a period of 30 seconds, you are evaluating the heart rate by palpating for the umbilical vessels at the base of umbilicus between your index finger and thumb, and you can count the heart rate, the pulsations for a period of 6 seconds. And as has been very nicely explained by Dr. Saluja, this can be multiplied by 10 to get a heart rate per minute, and if it is less than 60 per minute, then we have to also provide chest compression. Now it's very important that when you have to provide chest compression, you have to recruit another person in resuscitation, and that is the reason why it was emphasized in the beginning that a team of 2 persons is required for neonatal resuscitation. So the moment there is an indication to give chest compression, then one of the persons would continue with the bag and mask ventilation, and the other person would also start the chest compression. The person who is providing bag and mask ventilation should be preferably stationed towards the head end of the baby, and the person who is providing chest compression should be stationed on the right side of the baby.
I think, Dr. Mathur, the first session time is going to be over. We will continue in the next session the chest compression, and also we will demonstrate all the steps, initial steps, and we will demonstrate a full procedure, proper procedure on neonatal resuscitation in the next session. I would request all the program in charges who are still at the regional centers or the teleconferencing centers, please send your questions, and also request regional directors to send the attendance whether the student is attending the session or not. So you have to be back after 15 minutes so that we can continue the session, and you will have a very skilled demonstration on neonatal resuscitation by these 2 experts. So please stay with us for the next session.